So my name is Cervical. I am a gynecologist from Ethiopia, currently working for ICAP. So I would like to welcome all of you for the second session of African Cancer Research and Control ECO. This is a community of volunteers who meets monthly. The objective of African Cancer and Research ECO mainly is to discuss on evidences based in initiatives and interventions to advance cancer control in Africa and strengthen interaction and collaboration among researchers from regional and international partners. So we have audiences from government representatives, policymakers, program implementers, healthcare professionals who are interested in cancer control, survivors, cancer survivors, and advocates, and others. So the values that we are following as African Cancer ECO is respect, integrity, compassion, innovation, and stewardship. So without wasting too much time, I would like to say a bit about the objectives of today's session. I would like to say a few words about today's objective of today's session and introduce subsequently with case presenter and didactic presentation, and subsequently we expect to have questions and answers. So if you have any question, please stop me anytime or put some of your questions in the chat box and show your hands as well. So probably it will take 1 hour and maybe 20 minutes. So we hope, and I hope, that we'll have very interactive session. So to begin with, Ethiopia, like other sub-Saharan Africa country, has a high burden of cervical cancer, according to data from a cancer registry in Addis. Cervical cancer is the leading cause of cancer deaths, and the prevalence also very high. This is despite all the effort that has been undertaken for cervical cancer prevention using VIA, cryotherapy, and thermal ablation, and the LIP in a single visit approach. Just to bring you to the background or the landscape of cervical cancer prevention in Ethiopia, we have a national cervical cancer prevention strategy document. Cervical cancer is under Disease Prevention and Control Directorate, and there is a cervical cancer unit there. 2 health professionals are running the department, and there is technical working group supporting the team. Cervical cancer is implemented in more than 1,200 health facilities, which is like 30% of all health facilities in Ethiopia. We have 51 LIP facilities and 3 radiotherapy centers. We have a national cervical cancer guideline where the age, the frequency of screening, and everything has been well outlined. Despite all this, the program coverage is very low, according to Ministry of Health's website report. Coverage of cervical cancer screening is 10 to 12% in the general population and 65% for women living with HIV. So we conducted a sort of a pilot implementation of HPV DNA, integrating HPV DNA into the existing VIA-based strategy for 70 health facilities, and Salamoit is going to present the findings, the comparative advantage of HPV DNA, and the minimum level of health service infrastructure that is required to undertake HPV DNA in the existing health system. That will be covered in the presentation. Later on, Dr. Sebastian is going to present didactic session on implementation of HPV DNA in Germany. Dr. Sebastian has a lot of experience in different African countries. So we expect that we can extract some important information that will help us as an input for policy change, because WHO currently is recommending HPV DNA as a primary screening modality if we need to attain cervical cancer eradication as a public health problem, especially so in sub-Saharan Africa where there is a high prevalence of the disease. So saying so much as an introduction, I would like to invite Salamawit, she is currently working in the Regional Health Bureau, Cervical Cancer Program Advisor. She has a lot of experience on HIV-related, program-related services. So I will leave the floor for the presentation of Salamawit. So she will be presenting about HPV implementation findings in Ethiopia. And subsequently, Dr. Sebastian will take the floor and he will present the didactic session. So feel free to stop me anytime. If you have questions, please put your questions in the chat box. Thank you. So I will invite Salamawit for the presentation.
Thank you, Dr. Rizkel. I'll be sharing my presentation. Good afternoon, everyone. Is it visible to everyone?
Yes.
Okay, thank you. My name is Salamawit. I'm from Ethiopia. I'm the Addis Ababa Regional Cervical Cancer Program Advisor. I'll be presenting you the experience of Ethiopia on HPV DNA testing. We've been implementing HPV DNA testing for the past 1 year previously, and we have recently reinitiated the screening. So we will be discussing about Ethiopia's experience on HPV DNA testing. My presentation outline will cover on the background and preparatory activities implemented regarding HPV DNA testing service initiation, what the implementation finding in Ethiopia is, and some of the challenges we faced and the way forward we put. So just to give you the overview, as we all know, WHO suggested that HPV DNA testing to be the primary screening option to prevent cervical cancer screening, so our country adopted WHO's guidance in 2021. We have updated the guideline we use for cervical screening program in 2021. So we've accepted the approach to use HPV DNA testing as a screening option, just like suggested by the WHO guideline. So ICAP, with the funding obtained from PFR CDC, is supporting this implementation status in collaboration with Ministry of Health and regional health bureaus. So the HPV DNA testing was initiated at selected 70 health facilities. So as a preparatory activities, we've selected the testing sites, the testing labs, and the referring sites. These are health facilities with high load of clients on ART. So these are high load, high impact health facilities selected from 6 regions. So then we give training and orientation to the healthcare providers. Since it's a new screening modality, they were oriented for the screening option. Then the referral mapping was done. So which facility will refer to which testing lab was set. So then target was given for the referring sites in order to guide and monitor their performance. Standard operating procedure was developed and shared to the health facilities as well as the regions. And cervical cancer registration previously did not include the HPV DNA testing, so it was revised to include the HPV DNA testing modality. And some of the job aids also distributed to health facilities to facilitate the implementation. So when we see the implementation status, 15 testing sites were selected, 10 Abbott and 5 Roche, and 70 referring health facilities were selected from 6 regions. The regions were from Addis Ababa, Amhara, Oromia, Southern nations, and Sidama and Gambela. So these regions were selected. These regions are supported by PFR. And HPV DNA testing implementation started as of April 2021, and it continued up to March 2022. Currently, we've reinitiated in September. So these are some of the tools we used during the implementation. So the first one is the SOP we used for HPV DNA testing implementation. The second one is a laboratory request, and this one is a updated register that includes the HPV. And this was a job aid distributed to help and guide healthcare providers. So when we see the relation of HPV DNA testing with the socio-demographic status of clients, so when we see the age variable, so majority of the clients from the age of 21 up to 50 were the majority of the clients screened with this testing modality. And when we see the positivity rate, those aged less than 20 had highest positivity rate compared to the others. This is maybe due to the screening, the number of clients screened were less in those less than 20 years. But when we see those between the age of 21 to 30, there were around 38.6% of the clients had positive results. The HPV DNA testing positivity rate is lower among those between the age of 41 to 50 years. And when we see the regional contributions, so majority of the clients were tested from Addis Ababa, Amhara, and Oromia region. So when we see the positivity rate from these regions, so most of them had around 30% positivity rate, most of the regions. But when we see the Sidama region positivity rate is around 25%, so it's lower compared to the other regions. So when we see the screening type, so we have 3 screening types. The first time, the rescreening and post-treatment screening. So majority of the clients were first-time screened. Around 90% of the clients were first-time screened. 9.4 were rescreened, and post-treatment screening contribute to 0.2%. So when we see the positivity rate, around 31% from those rescreened clients were positive. This has the highest positivity rate, and when we see the first time, it's around 30%. So these two contribute to the highest positivity rate. When we see the clients' CD4 status, CD4 count status, those clients which have less than 200 CD4 count had the highest HPV positivity rate, which is about 52%. But when we see those clients which have CD4 count above 500, they have less positivity rate, which is around 28%. And when we compare to clients with viral load, when we see the client's viral load status, those which has highest viral load, like greater than 1,000 these clients has the highest HPV positivity rate, which is around 35%, and those with viral load of less than 50 has the least HPV positivity rate. So when we compare the VIA and HPV positivity rate with age trend, so when we see the HPV DNA screening option, those between the age of 20 to 30 years has the highest HPV positivity rate. And when we see the VIA screening option, those between 20 to 40 years has the highest VIA positivity rates compared to the other age groups. So HPV DNA positivity rate is lower among women aged between 41 to 50 years, and the VIA positivity rate is also less in those between the age of 41 to 50 years. So when we see the genotype distribution among those tested for HPV, so when we report the genotype, there are 4 options. So we report as subtype 16, subtype 18, mixed, and other. These are the 4 categories that the report is received from the testing labs. So the highest contribution is those with other subtype. So they contribute to 59% of the clients, and the second one goes to the those subtype 16, which is around 13.5%, and the list is from those subtypes with 18, which is around 3.5%. So there are also results that has no documented finding of that genotype. So there were around 628 results with no genotype mentioned. So when we see the HPV as well as VIA positivity rate, these are clients that are both positive for HPV and VIA. So majority of the clients with other results, which is around 48.7, were positive for both VIA and HPV, and subtype 16 has 14% positivity rate for both VIA and HPV, and the list goes to the subtype 18 with 3.2%. So during this 1 year period, we were able to screen about 12,321 clients, and out of those, 29% were HPV positive. So we did VIA for 95% of the clients. So this is a good achievement. And when we see the VIA and HPV positivity rate is around 20%, 23%. So 801 clients were both HPV and VIA positive. So we were able to treat around to 96% of the clients were treated. The rest has different reasons. They may refuse treatment, or they may we may not be able to access these clients. So when we see the modality of treatment, majority of the clients were treated with cryotherapy, around 57%. Then comes the thermal ablation, with 29% of the clients were treated. Lip treatment was given to 71 clients. Unfortunately, 22 clients were not, we were not able to treat them due to different reasons, and 10 of them were treated with other modalities. So when we see the turnaround time of the HPV DNA result arrival, so the median is around 21 days. So minimum of, we were able to receive the result with a minimum of 8 days at some facilities or testing labs at some regions, and the maximum TAT was around 93 days. So when we see the HPV DNA result when we see the HPV DNA result arrival to treatment, or the day that the clients came for treatment.
Salam, we are not listening. You are muted. I'm not sure what happened to Salam. So until she comes, then let me, okay. Salam was telling us about the turnaround time. On average, it's like 26, but the maximum is like 96 days.
Excuse me, doctor, can you hear me?
Okay, please go ahead.
Was there any interruption?
Yes, there was interruption. Now you are coming.
Okay, so shall I proceed with the challenge?
Yes, please project the slide first. Yes.
Is it visible?
Yes, visible. Yeah,
Hello?
please proceed. Yeah, proceed, Salam.
Is it visible now, Dr. Scale?
Yes, please go ahead. Yes, it is visible, Salam. I think I don't know what happened.
Can you hear me, Dr. Scale?
Yes, please. I'm hearing you.
Okay, I'm sorry. There was network interruption. So I will be continuing with the strengths. So some of our strengths were there was strong engagement from all stakeholders, the CDC, the Ministry of Health, Regional Health Bureau, EPHI, and all the testing facilities were strongly engaged in this program. And there was a good monitoring and reporting platform established. There was a good system to monitor the progress of HPV DNA testing, and demand was created among clients by the healthcare workers and other volunteers as well. So the availability of the self-testing option has improved the client's preference of cervical cancer screening. So clients were satisfied with using the self-testing options. So the major challenge was the fear of speculum. So this self-testing option avoided that. So clients really preferred this option, and it avoids lengthy stay during the time of COVID-19, and healthcare providers and as well as clients really accepted and preferred the self-sampling option since it avoids speculum. And sample referral and networking system was established. So every facility knows where to send and receive the sample from. The availability of all the M&E tools and provider support tools really helped facilitate the program. So when we see our weakness or our challenges, so some of the health facilities did not collect enough HPV samples, so they did not meet their target. So only few HPV DNA tests were done, and there was delay in initiation of HPV DNA testing at some health facilities due to different reasons. And not all the samples collected from health facilities were sent to the referring labs. Some of the samples stayed at the collecting facility, and there was long TAT at some of our testing labs. The results were not returned as expected or as a expected TAT, and clients, some of the clients refused to come to collect their positive results. Some prepare to wait their refill date than come and collect their positive results at the right time. So not all of the HPV DNA positive clients were screened with VIA and received the appropriate treatment. So the kit has the reagent has some short expiry date, and there was stock out of the test kits as well. So some facilities were not able to the documentation of the genotype, whether the sample was collected by self or provider. So this was one of the challenge. And our reporting system, our national reporting system, the HMIS system did not include the HPV DNA testing option. So this was one of the challenge we forced to report those clients screened. And there was lack of ownership and monitoring among some regions, so it was not regular. So the other challenge was there was no inventory system to purchase the reagent in the kit. So getting the reagent in the kit was a challenge as well. So that some of the opportunities we had was that there was existing system for viral load testing. So we utilized that existing system for viral load testing. So basically the referral networking and the testing labs also were used for the viral load test. So previously we used to use those testing labs for viral load testing. So it made it easier for us to implement the HPV referral mapping system. The other opportunity that we had was the Ministry of Health has a big interest to scale up and utilize the HPV DNA screening option, and the direction given by WHO to utilize HPV DNA as a primary screening modality really helped for the country to be engaged in this HPV DNA testing, and PFRCDC was willing to support this screening option in every way. So these were the opportunities we have for the implementation. So our way forward is that we are planning to lobby for more funding to be able to implement this HPV DNA testing without interruption and in every health facilities. To develop quality management and efficiently utilize the resources that we have. So we are really strictly monitoring the quality of the testing at the second phase of the pre-initiation of HPV DNA testing. So the other thing is the data collection and data use and analysis is really
Thank you, Salamoid. I think so. I think Salamoid has gone through her presentation. I think we thank Salam. So this pilot implementation is to collect local evidences for policymakers. I think Salam, you are muted. Are you speaking?
Okay, I'm almost finished. So
yeah. Thank you.
Yeah, thank you so much. I'm sorry for the interruption.
Thank you.
Sorry.
Yeah, so thank you so much. So this is like a pilot implementation finding that Salamite has presented. So now we are collecting evidences for policy makers to make HPV as a primary screening modality. If we have to bring significant impact on cervical cancer incidence and mortality in the country. So what Salamoid has shown us is HPV prevalence is one of the highest. It's around 30%. So it's really high in Ethiopia. And the other thing, what we saw is like HPV-16, which is a clear carcinogen. The prevalence is like 13%. These two things are really worrying me so much. So what we saw from Salamoid's presentation is that with existing infrastructure and manpower for VIA screening, with existing demand creation activities, we can somehow integrate HPV DNA with existing infrastructure for CD4 count and viral load testing platform. We haven't tested other gene expert machines and other PCR machines, but we integrated HPV DNA into the existing CD4 and viral load machines like Abbott and Roche. We learned that we can integrate it safely and initiate HPV DNA testing as far as we have the reagents available. We have explored ways to make adjustment in the health system, as Salam presented, especially on sample referral, collecting of the sample, calling the patient for triage and so on, needs some modification in the health system. That we explored, and finally, we have a courier system that transports the sample that we make it. That's why we have like high triage performance in the country. We have somehow developed a data collection system. So what I can say at the end is one can initiate HPV DNA testing in resource constraint setups like Sub-Saharan Africa. That is a lesson that we want to demonstrate for policymakers. I think now I can see Dr. Sabstian. He had a difficulty to get in because of maybe the network. I don't know. So
Hi,
Dr.
yes,
Sabstian,
I'm here now. Thank you.
Yes.
Nice to see you.
Yes, welcome, Dr. Sabstian. We had the case presentation about pilot implementation of HPV DNA in certain selected facilities with all the challenges, and the success has been discussed. So we want to see experiences from Germany. I know it's quite a different setup, but what's lingering in my mind always is there is low public awareness in Sub-Saharan Africa setup because the literatures are telling us that. And probably there is high public awareness in the Western countries. Even though we had a technology and a reagent and all other things, if the public awareness is not as high, then the uptake could be low. So can you please tell us the experience in Germany? The floor is yours. Welcome, Dr. Sabstian. You are muted.
Of course, I would love to. Thank you very much for the invitation, Dr. Eskiel. I want to share my screen. But where can I do this? Okay, there we go. So I guess everybody can see this now.
Yes, we can see it. Make it a full screen.
I was asked to talk about the German experience in cervical cancer screening. First, I have a disclaimer. I received sponsoring from pharma company Gideon Richter within the last 5 years, but it has nothing to do with the current topic. In Germany, we have, if we talk about cervical cancer screening in Germany, we have to take into account that the cancer screening changed in 2020. Before 2020 in Germany, we had a so-called opportunistic screening program that had been established in 1971. It should be mentioned that the whole program is completely in private hands. Germany is full of gynecologists that are working in private practices in an ambulatory setting, and women are asked to go to these professionals to have their screening. It's an office-based cytology screening. In Germany, we have a mandatory health insurance system. That means everybody, every woman, every man, every child is mandatory health insured. If they cannot pay for it by themselves because they have no job, then it's the state that pays for them. So everybody in Germany that needs medical treatment gets it, so to say, for free. They don't have to pay at the entrance of the hospital. And some of the screening programs are also free of charge for the patients, so to say. This opportunistic screening included once a year for every woman, the taking of a medical history, a clinical examination of the vulva, the vagina, the cervix. A pap smear had been taken once a year. It had an inspection and palpation of the breast from the age of 30 and a rectal examination from the age of 45. This had been done over the last 50 years. If we look at this system now, we see that there was an overscreening of young women and an underscreening of elderly women. I can show you in the next pictures why this is so. It was no population-based call or recall system. So the women in Germany, they knew about the system, but they were not directly invited to take part in the system. It had no clearly defined triage strategy. That means if there was a positive pap smear, of course, there were medical guidelines what to do, but the whole system was based on taking these patients then to a nearby hospital and be taken care of. We had no certified colposcopy centers in Germany until 2015. Colposcopy is part of the education of gynecologists in Germany, but the uptake was so-so. In Eastern Germany, a lot of gynecologists were used to doing colposcopy. In West Germany, it was not so common. And it should be mentioned that in Germany, there was no real cancer registry for the whole country. In some parts of Germany, it existed, but not for the whole country. So here in this picture, you can see the attendance rate by age. 100% means all eligible women from the age of 20 until the age of 80. And then for every age group, the attendance, so it started with around 60%, went up to 64%, but then declined. But overall, it's a quite good uptake rate. And what happened since 1971 with cervical cancer in Germany? Here you see the graphs, the incidence of cervical cancer per 100,000. from the year 1966 until 1993 in different countries. It's still divided into former East Germany, the brown graph, or the purple graph here, former West Germany. So the numbers were quite different. We started with for European circumstances, quite high number of 30 to 35 per 100,000 cervical cancers. And during that system, the number decreased to around 12 to 13% in 1993, which was among the European countries so to say, good result. This is the age standardized mortality and incidence rate of cervical cancer from 1999 until today. So the upper graph is the incidence. It was, as we said, 12 per 100,000. It is slowly now dropping into 9. The mortality rate does not really change over the years. Age-specific incidence rates in Germany, again, 100,000 per year. The peak is at around 40 to 45 years, and then there's another peak in the later ages at around 60 years. So this program had been going on for 50 years, as I told you, with quite mentionable success. But science has made progress. Meanwhile, we have HPV testing, and we know from scientific studies, and this one is an example for it, a follow-up study of randomized controlled trials in Europe on HPV testing. It could be shown that HPV-based screening provides a 60 to 70% greater protection against invasive cervical carcinomas compared with pap smear cytology alone. Data of large-scale randomized trials support initiation of HPV-based screening from the age of 30 years, and it can be done by an extension of the screening intervals to at least 5 years. That is what science tells us. So what did we do in Germany with these results? We invented a new screening system in 2020. It's called the Organized Cervical Cancer Screening. It's been inaugurated 3 years ago. The first evaluation is planned for 26. And what's happening now is women from 20 to 35 years of age, they receive a pap smear once a year. Above the age of 35, they receive a pap smear and an HPV co-testing. If it's negative, then they only have to show up at the doctor in 3-year intervals. These 3 years, as we mentioned before, studies tell us 5 years would be enough. But you know, over the last 50 years, there's quite a large group of gynecologists in Germany that really live on this work, and this is how they finance their lives and their families. So it was like a compromise to tell them, okay, at least every 3 years they come to your place, and because gynecologists, they get paid for doing these tests. The next 2 slides seem to be a little bit confusing and complicated, but at the end, they are not much complicated. It tells us what to do if a pap smear in the age group before 35 becomes positive, what to do with these patients. And in the next slide, I show you the algorithm, what to do with patients with positive findings at the age above 35 years. So for the younger age group, if they have a normal pap smear, they go there every year. And the reason to do this is, the reason to do no HPV testing in the younger group is the HPV prevalence in this group is so high, but most of these women lose their HPV status over the time and are under no real risk for cervical cancer. So under the young woman, HPV testing makes not much sense, so we skip this in the younger group. So in most cases also this is negative and they go there once a year. If you have minor changes, you will have cytology retesting after 6 to 12 months, and a combined HPV test. And then it depends what of the outcome. If the HPV test is negative in that younger group, they go to the annual cytology. If the test is positive, they receive a colposcopy and then further steps in case of major findings. In the older age group, 35 years and above, patients receive an HPV testing together with the pap smear. So if it's negative, they go to see the doctor again after 3 years. If it's positive, they have an almost similar algorithm with minor changes to be repeated tests and with major changes to receive a colposcopy, biopsies, and if it's positive, then cervical cancer treatment. Let me say a few words about HPV vaccination in Germany. I know you had this, that was your topic the last time, but I just want to give a complete picture of what we do here in Germany. The HPV vaccination had been introduced in Germany in 2007. The coverage was 5 to 60%. Now in 2012, the coverage was 40%. And here on the right side, you see the dates for 2022. Also, the vaccination of boys had been inaugurated in 2018. That's why you see the rates here. A first dose, 66% of females in Germany have received. A complete vaccination with all the 3 doses was in 30%. In boys, the first dose received 54% of the boys, and a complete vaccination 17%. So there's still some work to do, but we already see good effects. A surveillance study that had been done on 2,000 young women showed that in the youngest group that had been fully vaccinated, HPV 6, 11, 16, and 18 as the main targets had been eradicated. And even in the group that were not vaccinated, there was a significant reduction in these viruses. So it shows us that this HPV vaccination will have good effects in the future, although the coverage is not as good as in other countries. Let's say in Scandinavia, they have a better uptake rate. In Great Britain, they have a better uptake rate. In Australia, they have a better uptake rate. To come to a conclusion, I want to say we have 2 age-dependent screening algorithms in Germany. As I said, at the age from 20 to 34, an annual cytology, a pap smear, and in case of abnormalities, a triage HPV test after 6 to 12 months. For the older age group, 35 and above, we have a co-testing every 3 years, and only in positive findings, a colposcopy and further steps in diagnostics and, if necessary, treatment of cervical cancer. To have a system like this is quite costly, as you can imagine. So it depends on funds. In Germany, it's the mandatory health insurance that pays for all of this. Also, in the meantime, we have invented colposcopy centers with trained professionals and organized quality management. So they have to send in their pictures from time to time to be controlled, so to say. And also what I want to add at the end is, if you set up a screening system for cervical cancer, you have to make sure that you can treat the patients if you find them out. So there's no use having a screening system if you really cannot treat the patient. So if you have the system, you have to make sure that there is enough space in hospitals or practices to treat these patients who are tested positive for cervical cancer. And with this picture, I want to thank you for the invitation and say hello from Düsseldorf in Germany. Thank you very much.
Thank you. Thank you. Thank you, Dr. Sebastian, for a very nice and informative presentation. So much thank you. So I want to highlight the fact that HPV DNA screening or incorporating HPV DNA has brought in a scientific papers 70 to 80% reduction of cervical cancer. I think this is something similar to other studies as well. So the Gynecologist Association or the Ministry of Health of Germany didn't keep quiet with this finding. That's what I take as an important point from the presentation. So we are now aspiring to initiate HPV DNA in sub-Saharan Africa. How, when, are some of the experience sharing talks that we are having now today. So now I leave the floor for questions and answers. So your question could be to Salam or could be to Dr. Sebastian. So please raise your hands or put your questions in the chat box. Whoever wants to share his experience or wants to suggest something or have questions that need clarification, please go ahead. To begin, I see hand. Moses, please go ahead. Introduce yourself and go ahead. John.
Yes, good afternoon, good morning. Thank you for the chance and thank you to the presenters. And it's a bit interesting that we have these two areas being discussed in a different context that we serve in. It will be interesting to know how the German healthcare system has been able to entrench, both legally and policy-wise, the testing and the screening that has just been described, extending all the way to the boys, and the fact that they have also been able to increase the number of gynecologists who know what they need to do for their practice.
Sorry, I didn't really understand the question. There were two questions, but the connection was not so good. So the first question was how the German health insurance system had been inaugurated or how it had been established. Was that your question?
Yes, that's the question.
Well, to be honest, the German health care system is one of the oldest in the world. In fact, it had been invented in Germany in the 1880s or something. So the first health insurances had been established. So there's a long history, and that's why the system is so well established in the country. The system survived the monarchy, it survived the Nazi regime, and is still there. So everybody who is employed pays a share of, let's say, about 15 to 16% of his income to health insurance. And for those who are not employed, the state kicks in and pays their share. So that's why it's possible to make these arrangements, and that's why we have so many hospitals, and it can be taken care of everybody. But the price we pay is quite high. It's like 16% of the income of everybody. So this is the money that the German state can take to set up infrastructure and pay the doctors and nurses and stuff. And the second question was, why are boys vaccinated? Was that the question?
No, the question is the fact that you stated the vaccine uptake has been high, but also giving the fact that if you cannot treat after screening, you should not screen. And the question is, how are we able to implement that? because given our context, everybody is doing the tests, but there's a disparity between those who are doing screening and those who are treating.
Yeah, I mean, this is when I was thinking about giving that talk, and with a few things I know about medical system in some African countries. That was one of the things I wanted to mention, that you cannot only test for something, you have to make sure that you can treat if you find out somebody who suffers from it. And since I know that this is a round of people who are from that branch and are caretakers and also decision makers, that should be taken into account when planning systems like this. This is my opinion. This is my personal opinion. Huh?
Okay, thank you for that.
Thank you, Dr. Safsan. I think it's a good point. From some of my literature reviews, I see that when there is an insurance system, the uptake of cervical cancer uptake has significantly improved in many different countries. So I think it could be a good point to consider in sub-Saharan Africa as well. Yeah, it's a good point. So I see hands, Daniel, please, and then Waya. Is that order? You can continue, please. I see your hands.
Okay, thank you very much. Thank you very much, Salah, for the excellent presentation and for the excellent work that you are doing in Ethiopia. It is, in fact, very, very impressive. I just want to find out, in your program, did you find cultural and religious challenges in women? Did some women refuse to be enrolled into this program due to their cultural or religious background? Because this is something that is a serious challenge in most African countries. Thank you.
Thank you. I think let me respond to some of the questions. You raised an important point. Definitely culture and religion had an impact, but I think I cannot give you like quantitatively the measure, but it is really an impact. So what I think is the self-test of HPV is a very good way out, relieving health professionals from excess burden, as well as the fear that some patients have on intimate examination like speculum examination or things like that. So the self-test, when properly demonstrated, will definitely address challenges related with religion or culture and the like. That's my point. So Salam, if you have anything to add, you can please add on this.
Okay, thank you. That was a really interesting question, because most of our clients don't want to show their private parts to healthcare provider due to their religion or cultural issues, and some may request a female provider to see them due to religious reasons. So as Dr. Scale mentioned, the initiation of cell sampling in using the HPV DNA testing really helped improve the screening of cervical cancer. So the initiation of HPV really helped us in this area. Thank you.
Mayala, Evelyn, please. I see your hands.
Thank you so much. I want to address this question to Dr. Sela. Great work that is being done there in Ethiopia. In your presentation, you mentioned something on the weaknesses. I just want to know or find out, you said not all samples collected and referred are tested. So my question is, what becomes of the patient that actually the sample was collected from? And what is the waiting time from the collection to the result? if all the samples collected and referred were not tested, what becomes of the patient? What do you tell the patient in terms of the result? Thank you.
Okay, Salamoit, you can respond to this, and then we'll go to Moses next. Salam, if you have anything to say to this question, it's an interesting question.
Okay, so the result of the clients may not reach the testing labs due to different reasons. Some of the reasons could be the transportation system, the failure of the postal system. Some of the samples may not reach the the testing labs. So what we do is we cannot tell the client the results since testing has not been done. So we contact the clients to come and give second sample and do the testing again. Then after that, we can tell the client their results when the final result reach the facility. So it will take a lot of convincing to get the clients to come back for second tests. So it's a challenge. And what we are doing is to minimize those samples that are not that are collected from the patient and not reach the testing labs. So we're trying to minimize that on the second phase. So the turnaround time, as I mentioned previously, it could go from the minimum of 8 days to a maximum of 93 days. So the median is around 21 days. Thank you.
Just to add a few points from what Salamoit has said, this is like a project on progress. So we are learning as we are doing. So we give the most important thing we understand is like giving proper counseling. Take time to counsel so that the patient really understands. And now we have developed a small, like 5 minutes video in all our mobiles. So we just show them what's happening on the examination and so on, so that they understand, especially the self-test. And the second is give appointment, not very short appointment, give them like 4 weeks time. So we make sure that in 4 weeks time, the result arrives. And we assign some airtime budget for healthcare providers so that they just call, not out of their pockets. This is an extra cost when we are thinking of HPV DNA, initiating HPV DNA as a program. Thank you. I see hands. Moses, please go ahead if you have questions or comments.
Hi, how are you doing? Yes, my name is Moses. I work with the Uganda Child Cancer Foundation. Mine is not really a question, but more of an observation and perhaps something that colleagues from within Africa can be able to either pick up from or develop on. We at the foundation, we have a program that we call 3C, that is Children Caring About Cancer. And this program, we have put it in high schools. So in the high schools, what we're doing is we're teaching these young people about cancer with the goal of ensuring that, one, we're teaching the next generation about cancer so as to reduce on late diagnosis in the future. Now, because of the interactions that we have with these young people in the high schools, one of the things that has evidently come up is the issue of HPV vaccination. So you find that the young people are willing to get the HPV vaccination, but the hesitation oftentimes comes from the parents, because you'll find that before the school accepts vaccinations, they need the go-aheads from the parents to the children. So in a way, it is easier to approach young people from the high school, from schools, but the big question still lingers on the parents. How do we convince the parents about the benefits of the HPV vaccination? In as much as we have tried to give the relation to the first world countries, how cervical cancer is not a very big problem as compared to us in the low middle income countries, you still find that there's still that hesitation. The belief is that these vaccines are dangerous to their children. So yes. Yes, Benda, I think I'll share with you my email, and then we can be able to have a conversation on more about what the 3C program is. Yeah. Thank you.
Thank you, Moses. I think it's a very interesting point that we raised. I think I am very much willing to listen more about this experience. So educating the young is like educating the next generation. So taking more time on the education, I think, should be a way forward, so that people come for screening, they are convinced about what is going on, and they understand the whole system. So it really relieves the burden and improve the outcome as well. So culture sensitive, appropriate utilization of health education messages and the like are quite important. I think this is very important thing to listen. I don't see any hands, any hands there. Okay.
Mine is up.
Banda. Okay. Yes. How are you doing?
You.
Okay.
Thank you. Hi, Ezekiel. So
Yes,
thank
fine.
you so much to the two presenters, quite insightful. And why actually I've written to Moses to request for more information is because this is quite interesting to see a childhood cancer organization being the one that is actively involved in educating about HPV vaccination. It's something that we've tried periodically with some of our childhood cancer organizations in Kenya, but it's periodic, not sustained. So it would be valuable to learn from you, Moses, around how you've done this, how you're sustaining it, and how it can be integrated in other African countries around elimination of cervical cancer. We need to build champions from the young age, and that will benefit other cancers as well. To Dr. Sebastian, a question. I noticed in data from the 70s and 80s, Kenya, I am from Kenya, Kenya and Germany had a similar age standardized incidence as well as mortality on cervical cancer. That was at about 40.5 to 100,000. Germany has moved milestones and big strides. Kenya is still at the 30 to 40 to 100,000. What would you say is the most critical factor, especially to governments, when it comes to cervical cancer elimination, and especially now that we have 2030 looming very close to the WHO targets? Thank you.
This is my personal opinion, but it depends on regular and it depends on regular funding. You have to have the money to pay this program. And okay, we call it mandatory health insurance, but I'm aware that you cannot take money from people you don't earn money. Yeah, and in low and middle income countries, up to now, they still depend on funding from governments, and the governments have to get their money from somewhere else. That's for sure. So it's a problem the WHO has to face, and the WHO as a political institution has to make programs with the countries and their governments and make sure that the money goes there where it is needed. So I think this is the most crucial fact. And on the other hand, you have to have an awareness in the population that if these programs are offered, that it's good to take part in them. And this, okay, let me call it a success story in cervical cancer in Germany. It is nothing that came like within 5 or 10 years. The awareness of the severity of cancer and the dangers of cancer has not been there since ever. It's also started in the 50s, especially in United States, when there were the first success stories of chemotherapy. Cancer became more and more part of daily life in people. They were talking about it, and there were organizations, NGOs that promoted the knowledge of cancer. And this took years, and this took money. These NGOs received their money from donors. And I'm afraid it must follow the same way in countries of Africa or other low and middle income countries. We need to have money for this, and we need to have the right people to do this, and we have to have enough patience to do this. It takes time.
Thank you.
Thank you, Dr. Sebastian. I think I can also support this saying that Germany cervical cancer is even less than vulvar cancer. So I think most of the gynecologists are currently treating precancerous lesions and cancer. So I think it's a very good success story, and it's better than seeing some papers to have Dr. Sebastian around live to discuss about this issue. I like it. Concerning the cost, I believe it's very important, but if we initiate HPV DNA, and if the government is approving it and lobbying for cost, I think there could be a room for bargaining the cost of HPV DNA. If we have a lot of, and if there is registration going on there, then the cost could probably come down. And there could be point of test machines around. So I think once the Ministry of Health is adopting this, then hopefully there will be some collaborations with different companies. I think we learn a lot from developed countries that the incidence of cervical cancer really has come down. And it's possible that it could really come down if we collaborate and use the best technology, science, and everything. Thank you. Banda, I am seeing your hand.
Yeah, it's out of curiosity. Yes, it's a new hand. And this is again to Sebastian. Dr. Sebastian, you've said it will take years. And you said it would take political goodwill from WHO as well as financial goodwill to bring resources to Africa. Civil society would need to be involved in a robust manner, and technical expertise to build into prevention and elimination. But at the same time, community engagement and awareness to create the need for the services, demand for the services, but also take of the services once that capacity is created. Now, my concern is this is a mouthful for us to take on, and 2030 is only 6 years away if we don't count this year. In your opinion, do you think there are things that Africa could do today to be ready for that, for 2030 that's coming very closely? I'm saying this because I know like only about 22 countries in Africa have national cancer control programs that include cervical cancer as a policy. So if we think about that in itself from a policy perspective, that's an uphill task. What do you think could be the one thing that we could do between now and in the next 6 years to get Africa at least on the pathway?
I'm not sure if I'm in the position to give advices like this, and I don't know a real good one, but I'm sure that the work you're doing already is most important, because we would not sit here in this round if WHO would not have said, let's eradicate cancer until this and this date. Of course, we see it might be a challenge to reach this goal. But even if we don't reach the goal in every point behind the comma, as you can see, even in an attendance rate that is not 100% rate, not 100%, we see a decline in cervical cancer. And if we can save at least a part of these women who would have had cervical cancer in the future, we're already successful. So, and that's why I think Of course, this goal is very challenging and it's a big goal, but we would not sit here if there was no chance to reach any of it. This is what I think.
Thank you.
Yes. I think we have to continue to do country-specific research, implementation papers, and show to the policymakers how good we can do with HPV, how costly it would be, how cost saving it can, how much life it can save, and the like. So we have to continue to advocate for it as we are currently doing. So I really thank all of you. And I leave the floor for Vanda to have a closing remark and finish the session. Thank you.
Oh, wow. I think I would just like to thank all of you for attending and to thank our two presenters, Salama White and Dr. Sebastian. Really, they were very insightful presentations. And I will not take much time because I think the Secretariat does have a bit of announcements to make. So I will leave the floor in the next 5 minutes to the ECHO Secretariat under Charles and Christine. Thank you so much for your time. Christine or Charles?
So thank you, Beda, and thank you everyone for joining us today. And of course, our speakers, we are really appreciative of you taking the time to share your knowledge with us. So we are really grateful. So today we are a bit few, and I understand there were some technical challenges that people encountered in joining. We are still trying to onboard everyone to IECO, and we hope that with time we are going to resolve all these challenges. So we are going to share this recording with our wider audience so that those who are not able to join because of technical issues will be able to access the documents, both the presentations and the recording, so that they are able to also get to run. So our next session will be held on November 16th, and we are going to be sharing the agenda in the coming weeks. So please look out for that. Otherwise, I don't know whether Christine, you have anything to add, but for me, just to appreciate everyone for your time. Thank you.
Thank you, Charles. I think you have done a good closing remarks. Thank you, Dr. Sebastian and Salamita, and of course, Ezekiel, the moderator. Thank you, Benda, too, and all our participants. Have a beautiful rest of the day. Bye.
Thank you. Ezekiel, thank you for great moderation.
Thank you so much.
Great control of time. Thank you.
Thank you so much.
Right.
Thank you.
Bye, everyone.
Bye.
Bye-bye.
Thank you, everyone. Thank you.
Bye.